Ladies and gentlemen, welcome to MedSynapse podcast, where we dive deep into the latest developments in the field of medicine. I'm your host, Dr. Nigar, and today we have the privilege of hosting an esteemed guest, Dr. Deepthi Vilasini. Dr. Deepthi is a medical oncologist with 17 years of experience, 13 of which have been dedicated to oncology. She is currently a part of Department of Hematology and Oncology at Sheikh Shakhbout Medical City in Abu Dhabi. With her extensive experience, Dr. Deepthi has managed a wide spectrum of cancer patients, handling solid tumor malignancies and hematological malignancies, excluding acute leukemia. As October is Breast Cancer Awareness Month, we are continuing our focus on raising awareness about this critical topic. In this episode, we will be discussing early detection of breast cancer with Dr. Deepthi Vilasni. Welcome, Doctor.
Thank you, Niga. Thank you for the invite and thank you for the introduction as well.
Thank you so much for joining us on this episode today. Now, without further delay, let's begin with our podcast. Dr. Deepthi, the doctors in our audience would like to know about the latest improvements in breast cancer detection techniques. Could you talk about any new technologies or research that seem promising?
Yes, Niga. So that's a very important and good question, I would say. To start with, I would still say that to detect breast cancer, mammogram is still the gold standard mechanism. And you can also have ultrasound and MRI to assist mammogram in certain situations, but it would still be mammogram as the gold standard. We would usually use ultrasound in case of dense breasts with young patients where you want to differentiate between cystic and solid areas. And it's also a very good modality for guided biopsies as well. And we usually use MRI as an adjunct in certain situations, especially if you have an occult primary, that is, you just have an X ray node and you don't know whether there's a primary in the breast. For screening for high risk patients, such as those with BRCA mutations, etc. But for all practical purposes, mammogram would be the gold standard. And considering newer techniques, I would say there is 3D mammogram, which is available right now, which is digital mammogram. This is more sensitive and specific to find out about breast cancer, especially in dense breast, more than the regular mammogram. But the constraint, if you would ask me, is that it's kind of very costly than the regular mammogram. Now, about newer developments, we have a lot of things in the pipeline, but nothing has come forward to actual practice actually. So, what we hear about right now, or what is in the pipeline, is a few of options. I can outline it for you. So, the first one is called CT mammogram, which is a form of a molecular imaging wherein you inject something called technetium based radioisotope and you image the breast with something called gamma imaging. Another technique that has been in the pipeline is positron emission mammogram. You might have heard of PET CT scans, right? So this is a PET mammogram actually. So and also we have some interesting data for deep learning, which is a form of machine learning, AI based, to help us to get more information from our regular mammograms. And then there is something called contrast enhanced mammogram, where you use a particular contrast to help with your mammogram findings to mostly to rule out whether you have something which you miss out from the regular mammograms. Using a contrast might help you with that. And there are other investigational investigations such as elastography, thermography, etc. You hear about it for some quite a long time, but we don't have enough data to use any of these in the regular practice at the moment. But hopefully in the near future we may get beyond our regular mammogram. And also you must be hearing about liquid biopsy, liquid testing the DNA to find whether a person has cancer way before it has formed in any solid organs. All of these are investigational. We do not have anything to the forefront at the moment. At the moment, it is still a regular mammogram, I would say. But hopefully, in the future, we would definitely have more investigational modalities. That would be it.
Now, in the field of early breast cancer detection, What are the big problems or disagreements that doctors should be aware of, and how can we deal with these issues?
All right. So I think the biggest problem is about screening, who should be screened and with what modality. So breast cancer mortality is reduced unequivocally with screening. But there has always been this question about whom to screen, at what age to start, what is the correct, accurate age for you to advise the women to start screening. So earlier on, there was some question around 40 versus 50. But at the moment, I can safely say the current guidelines, also taking into the fact that we are getting to see a lot of breast cancers in young women, 40 seems to be the ideal age for, at least as per guidelines from the US preventive task forces. So that was a area of really an area of concern, an area of confusion, which I would say has been partly solved with some recommendations starting from 40 years of age. And another thing I would say is that even though mammogram is the gold standard for detection, mammogram may not detect all cancers. Rarely it may miss a cancer, especially in dense breast. Patients with dense breasts are usually on the younger side, so, what I would suggest is if there is a high index of suspicion, you have a lady with a mass which is there, which is hard or fixed, you have a high index of suspicion clinically, it is worthwhile to have ancillary investigations, including a biopsy. And I would say, even if the true cut biopsy is negative, I would recommend an excision biopsy also in a patient with a high index of suspicion. So that's something doctors should be aware of. And there's something that I would want maybe the gyne colleagues also to know, that pregnant women especially has a likelihood of missing out on a diagnosis of breast cancer because it's usually dismissed as a case of mastitis or milk collection, like a cystic lesion or something due to milk collection. So usually our pregnant women usually come up with an advanced disease. So what I would suggest is always to keep a high threshold of suspicion, especially with characteristic breast lump or breast changes. And young age or age should never be a barrier, and pregnancy also should never be a barrier to go ahead with testing. And other things I would say is the social, cultural, and economic barriers. Sometimes you find that people do not go out to screening, or they stall screening, or even if they have a lump, they usually do not go ahead to have a look because of a lot of things like maybe it's cost based, maybe it's their cultural thing, maybe it's a social thing. There is nobody, somebody may be living alone, they don't have anyone to take them to the hospital. These are all the things that I would say are a big problem these days that we see. But other than that, what doctors should be aware of is always any characteristic breast lesion. Usually, the breast lumps are painless, but that doesn't mean that painful breast lesions will never be malignancy. So, always just to keep a high index of suspicion and go ahead and prove it otherwise for any patient of any age coming with a breast lump.
Thank you so much, Dr. Deepthi, for highlighting the challenges and problems that doctors should be aware of. And now, moving on to our next question. What are some common wrong ideas or myths about early breast cancer detection? And how do you clarify these misconceptions when talking to patients and other doctors?
Okay, so that's a very good question, Nigar, because this is something I wish everyone would know. Because once we talk to patients and even with some of our non oncology colleagues, we understand that there are quite a bit of wrong ideas floating around. So, one thing I would say is the first thing that I mentioned before as well: any woman at any age, pregnant or non pregnant, with a breast lump should be treated with a high index of suspicion. Second thing is male sex. Even though male breast cancer is very uncommon, even a male coming with hard breast lump should undergo the same investigations as a woman would usually undergo. Another thing that we have come across, like usually, is that mammogram causes radiation risk. There is definitely a very low amount of radiation with mammogram, but what we have to look at here is the uh, risk benefit ratio. So, mammogram potentially saves lives when it's used as a screening modality, and the amount of radiation is so minimal that it doesn't pose a challenge as something as a health hazard or something. So, that should be absolutely understood. Mammogram saves lives, and the radiation risk is very minimal. And another common thing that we find, especially in this part of the world, is that patients usually mention that I do not want to take a biopsy because I'm afraid the biopsy will spread, make the tumor spread more. So, this is something which we have to totally negate. A biopsy will not make the tumor spread. It's mostly the tumor characteristics which would detect, which would determine whether the tumor will spread or not. Biopsy will never make the tumor spread more. Another thing I've heard is about antiperspirants. So far, we do not have any data regarding that. Nothing to worry about at the moment. And another thing is bras. There has been some misconception about tight fitting bras causing lymphatic flow obstruction to the breast and all that. Again, there is no scientific data, and it should be okay. Another thing is induced abortion. It also doesn't have any connection to breast cancer risk. And a major thing is cancer is not curable. That's a pretty long-standing myth, I guess. It is certainly curable. This is why we have put a lot of impetus on breast cancer screening, because the earlier you detect, the more curable it becomes. And another myth that we have heard about is removing your whole breast is better than just removing the lump. So there has been quite a lot of standard phase 3 data we have, which have unequivocally established that lumpectomy is equivalent to mastectomy. There is no need to go for a mastectomy for if you think that you're getting any additional benefit. No, it's as equivalent as a mastectomy. Both are same. And another myth is that any patient with cancer will have to receive chemotherapy. So it doesn't have to be that way. The more earlier you come, or some of the breast cancers which are detected by screening can totally avoid chemotherapy as well. And another myth I would say is any patient who's on radiation. I've had some of my patients' family members coming and asking me whether the radiation will increase radioactivity in the patient, and the radiation can spread to the family. There is nothing like that. It's totally safe for the family to be with the patient while she's undergoing radiation. And pregnancy, getting pregnant after cancer, it is still possible, but breastfeeding from the preserved breast, especially after radiation, may be difficult, and there may not be adequate breast milk supply. But otherwise, pregnancy is very much possible, and patients can get pregnant post breast cancer treatment. And another, I would just stop with this statement, which is a common myth. And I have had a lot of patients come and ask me, what we need to spread the message is not all patients will have the same treatment. So, treatment is highly patient directed, tumor directed, stage directed, and type of tumor directed. Not all patients will have the same treatment, and no patient should compare their treatment with that of another patient. So, these are the common myths that I can think of right now.
Thank you so much, Dr. Deepthi, for shedding light on the common misconceptions surrounding early breast cancer. It's definitely eye opening to hear how these myths can influence the decision of the patients and even affect the practices of fellow doctors. Thank you so much for bringing a clarification to it. Now, with your experience, what advice can you offer to healthcare providers about how to explain to patients the importance of finding breast cancer early and getting the regular screenings, especially for those in underserved or at risk communities?
Yeah, sure. So this has to be the motto, I guess. Early detection saves lives. So why do we stress so much on early detection? Is because breast cancer can be a lethal disease, especially if you find it in the late stage. But having said that, if you find it in the earliest stage, it's absolutely curable, and also we can the most important part about early detection, I would say, is that not only is your chance of cure high, secondly, the number of treatment modalities you will have will be like directly proportional to your stage. So that if you find a disease at stage 1, you will have proportionately less treatment than someone who would be having it at stage 3 or stage 4. So that's one thing. So not only do you stand to you have a higher chance of cure, you will stand to have lesser treatment. And especially, as I said before, if you find it really very early, like breast cancer patients found by screening where the tumor size is less than 1 centimeter or zero point 0.5 centimeter, patients can even avoid chemotherapy. So I would say this is cost effective. This prognosis is better, and it's a win-win situation. So this is something that we should explain to the patients or to the community who is unwilling to get themselves screened. Is you find a breast cancer by screening, the treatment, what they undergo, as well as during the treatment, the number of treatment, and the side effects related to the treatment, all can be avoided, and still you have a higher chance of cure. So I think that should be what we should be letting them know. And unfortunately, if you find it at a stage 4 disease, breast cancer can still be a lethal disease. So you don't want that, and you would ideally want all patients to be diagnosed by screening. So I would explain it that way.
Thank you so much, Dr. Deepthi, for sharing your expertise and insights on breast cancer early detection. We truly appreciate your contribution to this critical topic with us today.
You're welcome.
And definitely, we're looking forward to many more podcasts together on such great topics. And to our wonderful audience, we want to extend our gratitude for tuning in with us. Your support keeps us going. If you're a healthcare professional, we encourage you to register on our platform to stay updated with the latest medical discussions and insights. And don't forget to subscribe to our channel to never miss an episode. Thank you all, and until next time, goodbye.